In today's video, we're talking about prostate cancer and artificial intelligence. There's a company called ArteraAI, and they created an AI model that looks at data that will tell you whether or not active surveillance is good for you for a 3+3 category 6 or a 3+4, so what we call low intermediate risk prostate cancer. But we're going to contextualize it. We're going to talk to Dr. Mark Schultz. He's a 30-year medical oncologist who is focused solely in prostate cancer. And we want to know how this data is helpful, where to put it in the context of your prostate cancer case, and so much more. So I hope you find this helpful. So in today's video, we're talking about ArteraAI. So they have two different types of assays or tests that we've seen in prostate cancer. In other videos, we've talked about, this test seeing if, the need for hormone therapy when it comes to more newly diagnosed men who are metastatic. But now we're looking at the active surveillance space, and we're also looking at what we would call low intermediate risk. So we're looking at Gleason 3+3, and we're looking at Gleason 3+4. Gleason 3+3 never metastasizes. We see this, that if a Gleason 6 patient has, any prostate cancer that is left, it's new cancer, it's not the same. We like to make sure we reiterate that because it's so important for patients to understand the context. But then when it comes to Gleason 3+4, back in the day, they would just treat it automatically because the 4 was present. And now in modern day medicine, they're now wondering, do we need to treat it? Can we watch it? And it seems like this is a patient-by-patient decision, as all things should be, because we want to make sure that prostate cancer is individualized. But this idea that you're not treating 3+4 is really kind of new in the last 5 years. We've seen it hit more of a mainstream market. So as far as, the context of this in ArteraAI, there's a lot of details that patients need to understand the context of in order to be able to decide whether this is a good piece of information to add to the puzzle and see if this is going to, increase their knowledge or maybe lead them in a direction in which they would see a treatment that go towards treatment, or maybe even get something that's unnecessary. Before we get into the details of ArteraAI, let's just talk about the, common terms that we see in these things. And really what we need to look at is this whole concept of, okay, is this information really going to be helpful? So when it comes to ArteraAI, it was fed clinical trials. Can we just talk about clinical trials for a moment? And really, we hear these words like endpoints, we hear these words like survival. What does this all mean?
I'm not an artificial intelligence expert, but I think I get the principles of what they're doing and how it works. The issue with prostate cancer, which I think lends itself well to artificial intelligence, is that you're taking, we'll call them semi-old-fashioned factors, Gleason score, how the prostate feels on digital rectal, and how high the PSA is. And doctors historically would look at higher PSA or higher Gleason score, greater risk, more aggressive treatment. These things would fall into three broad categories: low, intermediate, and high risk. In my book, we called them sky, teal, and azure. And the methodology is useful, but it does take practice and skill to be able to develop what the algorithm indicates. ArteraAI has actually put a quiz together where you can punch your numbers in, your PSA, your Gleason score, and it'll tell you if you're in the low, intermediate, and high risk categories, and that those categories then guide you to more aggressive or less aggressive, or even maybe no treatment at all. But because of the complexity of this, it's not surprising that if someone has a computer that can analyze it all for you and tell you which category you're in, that would be useful. And when you mention clinical trials, when you embark down a certain pathway with treatment and watch people over, say, 10-year period after the treatment was administered, you can go back and look and see if they had treatment A and had a 90% 10-year survival, or treatment B and had an 80% 10-year survival. Then that information is obviously useful for patients, and they can look at whether, if treatment A or treatment B, if the side effects were equivalent, then you would always pick the more favorable treatment. And many times in prostate cancer, the side effects are not equivalent, and so a patient has to weigh whether the 10-year benefit is justifiable in light of the fact that you may have more upfront side effects. So to have all this processed for you, artificial intelligence can give you a number even and project based on all these other men that have gone before you. They're basically profiling you and saying men of similar profile, their probability was 90% survival at 10 years. And since your profile matches that, that's what the AI does, is it matches your profile, then we would project a 90% 10-year survival rate. That is very useful. Obviously, it doesn't tell you if you're going to live 10 years. No one can. People are even dying of other causes. But that is the projected likelihood, and that's the best we can do for predicting the future.
Before I get to my next question, I just wanted to remind you that we have an in-person prostate cancer patients and caregivers conference coming up in September, and it's a great way to get your questions answered in person by multiple opinions all in one weekend. You can learn more at pcri.org/conference. Now please click that subscribe button because it's a great way to stay up to date with the latest videos that we have coming out in prostate cancer and men's health. We have so much more coming. And also, if you would like to support us financially, you can do so at pcri.org/donate. Now back to my conversation with Dr. Schulz. When you and I were talking about this, we were talking about the data that was fed into this AI model as it's analyzing all of this. And it was from 1994 to 2001. Well, we're here in 2025. That's like 25 years ago. And so much has changed in the world of prostate cancer. So how do we contextualize old data with new treatments?
Well, I think that's one of the big weaknesses. What I like about this is that it is asking patients to look at their profile, and I like the fact that it's asking them to think in terms of what outcomes am I looking for, in terms of have a cancer come back. Is the cancer going to kill me? Is it going to spread to my bones? Will I need to take hormone treatment again someday? All these icky things that you want to avoid. So I think when patients are shopping around, and I hope they're shopping around, that they're not just going to a doctor and saying, give me your best shot. I think that encouraging people to start analyzing these endpoints and projecting themselves into these different scenarios is very useful. The problem, as you point out, is that since in the last 20 years, we've had, I'd say, close to 10 big breakthroughs in terms of finding cancer earlier, treating it better, eradicating it with second-generation hormone therapy, spot radiation directed by PSMA scans. We didn't have targeted biopsies. We didn't have MRIs back then when all that data was generated. So when they called someone a 3+4 back then, often they never sampled the front of the prostate. Probably 20% of these people had higher grade tumors and still did pretty well. But those are probably the reason that we see these 10-year mortality rates in the 3 to 8% range for intermediate risk prostate cancer, which I contend in 2025 is ridiculous. If a person is appropriately screened with a MRI and a PET scan, and they, after evaluation, confirm that it is intermediate risk disease, the 10-year survival rates are going to be 99.8%. It's going to be very easy to keep such an individual alive for 10 years. And that wasn't the case 20 years ago.
Well, I think it's an interesting point because I think patients often watch our videos for the first time and they're kind of wondering about the survival statistics that we talk about. Maybe they're in a metastatic situation, but it's really dependent on when you catch the cancer. If you have this early screening and you're in these earlier situations where it's localized to the prostate, it hasn't metastasized, it's such a different ballgame than if something that has already left the prostate, especially when you have distant metastases and all these things. So when it comes to this test, it's exciting that we have artificial intelligence and it's exciting that we have, these new models coming in and analyzing data. But PSMA, as you mentioned, has changed so much of the process. So as a patient, let's say you have a patient who walks into your office and they say, yes, I want to take this, ArteraAI test, but I also want to make sure that I'm doing the proper screening protocol. How do I put both into context, Dr. Schulz? What would you say?
This test, I think, competes with some other genetic tests, which are trying to also enhance the D'Amico standards, the NCCN guidelines, the SKY, Azure, and Teal, low, intermediate, high-risk staging. So that has been sort of the backbone of projecting the future by categorizing your status as low, intermediate, or high. But it's by no means perfect. And so we have genetic tests like Prolaris, Oncotype, and Decipher that take a second look at the DNA makeup. Now we have Artura that takes a more precise look at the NCCN guidelines. It also independently looks at the pathology. If you're looking at the pathology, you're, in a sense, doing another genetic assay, hopefully somewhat enhanced above what the Gleason score is providing. So all these things are giving you a little more information, but in my opinion, they are not something that you can have as a standalone foundation for making a decision. I think that the information would be useful in situations where a patient is vacillating. Let's say they have 3 + 4 = 7, and they're calculating that the risk of cancer spread in the next 10 years is, 4 or 5%. Maybe they're 70 years old. We know the median survival of a 70-year-old is around 13 to 15 years with no cancer at all. And so that individual may find this test helpful if it comes back and pushes them toward the idea that there's a higher risk of metastasis. Maybe that would discourage them from doing active surveillance. Or if it came back with a very low risk of metastasis, that would be a vote in favor of doing active surveillance.
If you have a patient who has this, 3 to 4% risk of metastases in the next 10 years, I think that some patients, and this is where I kind of get concerned with active surveillance patients sometimes, is they don't keep screening and they don't keep getting their annual scans. So what would be the screening and scanning process in order to make sure that if somebody in that 3 to 4% range is deciding to embark upon active surveillance and they're going to go with that 96% chance that there's probability there's nothing going to happen, what, are we going to do to make sure in those 10 years that they're watching their cancer, they're making sure that, we're not having anything new, and that they can, if it does metastasize, catch it early?
Methodology is very important, and our practice relies heavily on MRI screening. The studies showing that going back and rebiopsying the prostate randomly, which seems to be still very, very popular, are much less accurate than just getting a good quality MRI once a year, checking a PSA twice a year. The power of the MRIs is not only do you see something or not, the power of the MRIs is that year by year you have a sequence where they have a very well delineated image of the man's prostate. And if there's a shadow or an area that's been tracked, they can see that with great resolution. And on subsequent MRIs, they can get the exact same slice and compare that image with the new one, looking for any evolutionary change whatsoever, any growth at all. It's hard to imagine that things that aren't growing at all, which is so frequently the case with prostate cancer, are surreptitiously spreading. Annual MRI performed in a quality center, read by experienced doctors, and then compared from year to year is the backbone of modern active surveillance. We can supplement that with getting a PSA twice a year just to make sure something really weird isn't happening. Probably the biggest struggle we have is not patients progressing off of their cancer. People that have been well selected for active surveillance stay on active surveillance a long time. But the issue of doing PSA testing, so many men have background prostatitis that causes their PSAs to be a little haywire. PSA has been sort of the backbone of prostate cancer for many years, but if you look at the information sources that we have now, it's probably the least accurate. So people do get scared sometimes because their PSAs bounce around. And in those patients, we will occasionally order a PSMA PET scan and make sure that we aren't missing something unexpected. Prostate cancer comes in many genetic variations. When we talk about prostate cancer as an entity, we're talking about the general mainstream types of prostate cancer, but we're always trying to protect people against those outliers, those very rare, unusual variants. You're talking about less than 1% of men that behave much more aggressively. Those do happen. If they are occurring, we want to detect them at the earliest possible stage.
So we do see that this test is covered by Medicare, and it's about $700 that Medicare set the price, but seems like it's no cost to the patient and it is covered. But what information do you need to give the company in order to get the outcome?
The company wants you to send in information about what the PSA is and what the physical exam, the digital rectal findings are. And then they ask for the biopsy slides so that those can be scanned and evaluated by the artificial intelligence. With that information, it has to be provided or ordered by a physician, but gives you results within a week or two.
So, as we have AI here in 2025, we're seeing this early use and early adoption into medicine when it comes to these, algorithms, and it's studying large amounts of data and being able to give us predictive factors. When it comes to physicians, it's kind of interesting because, doctors are doing this all day. They're kind of using, the information that they're given from the patient and the factors from the NCCN guidelines and kind of doing the same thing. Artura is looking at it a more calculated, it's machine learning. It's going to be a little more accurate than just a doctor, but there's other factors that physicians have where it comes to incentives. They work in these big medical, facilities where, there are certain treatments that are being pushed more than others. Sometimes they're a specialist in just one specific treatment versus being a generalist when it comes to all the treatments and what may be available to the patient. And so there's a lot of biases and factors and money and all sorts of things involved. I think all these doctors have a great heart and a great intent when it comes to, they want to save patients. They spent their lives training and this is what they do. But now we have these new models that will come into the space and kind of give us more non-biased information. And obviously every company, and there's multiple factors. For the most part, if they're looking at large data sets and spitting out a report, you're not dealing with a doctor who's telling you, no, this is the type of cancer you have, and this is exactly what you need, and I got your back. Don't go to anybody else. And so I think it's an interesting new world we're in. Do you have any advice to patients on how they can kind of weigh the balance between the two?
The modern medical world that I work in is stretched very thin. Time is limited. 99% of prostate doctors are doing both prostate cancer and other things. Your average urologist is taking care of bladder problems and kidney problems, sexual problems, and your average radiation therapist is treating breast cancer, colon cancer, lung cancer. So the complexity of what we've tried to hopefully simplify enough to make it understandable today is really profound. And doctors are smart and they work hard, but they are stretched very thin. A machine or a computer that, like you say, has no biases and just gives you an outcome is a nice starting place. My reservations, which I expressed earlier, of course, is that they're not in this machine learning, and hopefully in the future they will. Hopefully they will start incorporating information about PET scans and MRI findings and other aspects that are part of the decision-making process. But I think it's a good start.
It's exciting that we're starting to see artificial intelligence used with active surveillance here in prostate cancer. And ArteraAI is really cool that you don't even have to maybe take a blood sample or tissue sample and things like that. You can go ahead and send your information, including your biopsy results, over to them, and Medicare covers it. So it's pretty easy to get. So the access is already there. That is exciting. I think, as Dr. Schulz mentioned, you want to just make sure that you're paying attention to the context. Prostate cancer context is so important. I think a lot of patients find out that they have prostate cancer and, there's a lot of emotions and the mental load of all that, and they get treated very quickly and they rush into things without knowing what specific type of prostate cancer they have, or if they even get a result from a test or something that they're concerned about, it can lead them into a direction where maybe they're going more towards treatment when they didn't need it. And so what you want to do is talk to your doctor about these results, and you want to work with your medical team, and hopefully they're advocating with you, they're taking time and explaining things to you, and you have a good rapport with them. If not, you can go ahead and get a second and third opinion, and just make sure you have a medical team that is working with you, because that's very important. But you want to take the results and you want to look at them and you want to contextualize it within your particular prostate cancer case. Where is the prostate cancer? How is it acting? What is the Gleason score? What is my PSA doing? This should be another piece of information in a bigger picture. And that's one of the examples that Dr. Mark Moyad from the University of Michigan, he's our moderator at our conferences. He always talks about that all of this information that you're getting from these tests and these assays and all that, it's a puzzle piece in a puzzle. And then you want to get enough puzzle pieces together that you can take a step back and get a really clear picture of what type of prostate cancer you have, what are the treatments available to you if you decide to go upon treatment, and what are the screening protocols and the next steps. So as you're, taking this information in, if you do get a report that you're kind of concerned about, please advocate for yourself and speak up about your concerns. Your mental health, your emotional health, and just making sure that you know what clear guidelines and guidance you're going to get for the next steps is really important. I think a lot of times, sometimes patients get things back that they do have concerns about, and they're like, well, I don't really know what this means, but my doctor didn't really think it was a big deal, so I guess I should let it go. No, talk about it. And, you can talk to other prostate cancer advocates, support groups. There's a lot of resources out there that we're going to list in the comment section below. Another thing is, if you do get these tests, make sure you keep your medical records, make sure that you're bringing this up to your doctor, and that when you're looking at the results of this, that you're writing down your questions and bringing it into the doctor appointment with you, because it just helps to advocate for yourself and feel empowered during this process. Now, as it is exciting that we do have these new technologies, as Dr. Schulz mentioned, it is reading older data. So I just want to encourage you that if you do get a result where you are leaning towards treatment, there is so much happening in modern medicine here in 2025. We have new indications. We have hormone therapies that are, the second gens are being used earlier. We have early chemo. We have radiations that are doing really well. There are a lot of ways to mitigate side effects. There's a lot more information out there about what to expect. So do your research, talk to your doctor, and don't be afraid to speak speak up for yourself and ask questions. Now, another thing, if you are leaning towards active surveillance, please make sure that you do stick to that active surveillance monitoring and that you're, going through the different MRI scans every year, that you're getting your PSA tested. I see a lot of patients that call our helpline and they're active surveillance patients, and maybe they got comfortable over 10 years, and at year 10 they just decided, hey, I don't want to, I've always been the same. My prostate cancer has been acting fine. Well, that's fine, but you want to make sure to continue to do the screening, and because sometimes new cancers can arise and you want to make sure to catch those early. Prostate cancer, it really does matter when you catch it. And so please, I would encourage you, if you are an active surveillance patient, please continue the screening protocol. Now, if you need more help with your particular case, you can contact our helpline at pcri.org/helpline. These are prostate cancer patients who have been through this whole process, and they can help just get your information for you, help you gather it, and take it into your doctor's appointment so that you're more prepared. Another couple of resources I wanted to mention is The Active Surveiller, which is a blog by a man named Howard Walensky. He has done so much work when it comes to prostate cancer and active surveillance, and he shares his thoughts and his research on that blog. It's a great resource. I'll link it in the comment section below. And there's a whole organization like us, PCRI, that does active surveillance education. It's called Active Surveillance Patients International. They produce some incredible videos. Howard Walensky works with them, so do I. And they do some incredible work, and they're just a great resource. You can also contact them to learn more about ArteraAI, because I think some of them have had it, and you can learn about their experience. Again, we will list their website in the comment section below. Please reach out, please speak up for yourself, and most of all, do not forget you are not alone. We're here for you, and we appreciate you watching this video.